I'm Isabella Zaniletti, and I'm a biostatistician at Mayo Clinic. In this video, I will provide practical insights on the difference between two fundamental concepts in orthopedic research: correlation and causation. If you were ever in a statistics class, you might have heard the phrase correlation does not imply causation. In fact, correlation only implies that some association exists between two variables x and y. Causation, on the other hand, implies that a change in one variable causes a change in the other one. Unfortunately, correlation is commonly mistaken for causation, but the relationship between the two variables can be simply coincidental. Like in this example, if you conduct a study to examine temporal trends in incidence of breast cancer and the incidence of arthroplasty, you might observe correlation, but such correlation is purely due to chance. Correlation is mistaken for causation also in the presence of reverse causality. We think one factor causes the other, but it's really the other way around. For instance, very low BMI is associated with a higher risk of short-term mortality in TJA patients, but this is in part due to reverse causality, where low BMI simply reflects underlying poor health status. Another good example involves alcohol consumption. Alcohol consumption is related to several health problems. In turn, poor health prior to surgery could lead to cessation of alcohol consumption. Because of reverse causality, one would observe a higher mortality risk among those abstaining from alcohol. Possibly the most common reason why correlation is mistaken for causation is the presence of measured or unmeasured confounders. Confounders distort the true relationship between two variables. For example, in a registry-based studies, we may find that dual mobility constructs are not associated with a reduced risk of dislocation, when in reality, an unmeasured confounder, such as prior spine disease, influences the choices of dual mobility implants, as well as the risk of dislocation. The aim of most orthopedic studies is the identification of causal relationship between exposures and outcome. Three conditions must be met to make a causal inference. The cause precedes the effect in time, the cause and the effect are empirically related, and the relationship between the cause and the effect is not due to a third confounding variable. In randomized trials, the effect of confounding variables is minimized through randomization. Therefore, it is reasonable to assume that the observed change in the outcome or the effect is attributable to a change in the exposure or the cause. Consider the example in which patients with knee osteoarthritis are randomized to total knee arthroplasty, followed by 12 weeks of non-surgical treatment, or only 12 weeks of non-surgical treatment. The outcome is the change in KOOS scores from baseline to 1 year. Since randomization minimizes confounding and the trial includes a non-surgical treatment as the control group, it is likely that effect observed in the outcome is, for the most part, due to the surgery. Inferring causality in observational studies is challenging due to the presence of reverse causality and confounding. Reverse causality can be reduced through study design by prolonging the duration of follow-up, applying appropriate exclusion of patients and outcomes, or using more complex study methods such as Mendelian randomization. There are several techniques to reduce unmeasured confounding, such as propensity score calibration, instrumental variable methods, target trial framework, and negative control design. Let's examine a few of these in detail. Propensity score calibration adjusts for residual confounding in the error-prone main dataset by importing information about the unmeasured confounders from a smaller external gold standard dataset. For instance, we know that BMI is a confounder of the relationship between fixation type and revision. If this is missing from our dataset, we can use an external gold standard validation set that includes the same variables as well as BMI. A propensity score is calculated for the study data, as well as for the gold standard data, with and without BMI. Finally, the regression calibration is applied to adjust the main propensity score for the estimated error from the validation set. Instrumental variable methods rely on an external variable, the instrument, that determines the exposure of interest, but it is not associated with the outcome other than through its effect on the exposure. An example of this method is the use of institutional or surgeon preferences, the instrumental variable, for the comparisons of the risk of revision between hemiarthroplasty versus total hip arthroplasty for femoral neck fractures. Target trials, on the other hand, frame the research hypothesis and the statistical analysis in the context of an ideal randomized controlled trial, balancing covariates at time zero and waiting to maintain balance. The target trial approach is used to estimate, for instance, the causal relationship between surgeon and/or hospital volumes and postoperative outcomes. Finally, the negative control method. Here, if we observe an association between a variable not causally related to the outcome of interest, known as negative control exposure, and the study outcome, we establish residual confounding and evaluate different adjustments. For example, the presence of association between dislocation, the outcome, and cup fixation, the negative control exposure, would indicate residual confoundings that needs to be accounted for in the analysis. This is because typically there is no causal relationship between cup fixation and dislocation. To address the potential effect of unmeasured confounders, sensitivity analysis can be used. An alternative approach uses the calculation of the E-value. This metric is defined as the minimum strength of association that an unmeasured confounder must have with the outcome and exposure, conditional to the measured covariates, to explain the relationship between the two. The E-value sets two parameters equal to each other to determine the minimum for both. In conclusion, orthopedic investigators should carefully differentiate between correlation and causation when designing their studies or interpreting the findings in the literature. If an association is established, careful consideration should be given to the nature of the association, the temporality of the events, and the presence of confounders. If conducting a clinical trial is not possible, appropriate study designs and statistical methods should be applied to adjust for reverse causality as well as measured and unmeasured confounding.